much for this initiative. Welcome also to Dr. Lott. Dr. David Lott is professor and chair at the Department of Otolaryngology and Head and Neck Surgery and Audiology at Mayo Clinic, Arizona. Welcome. We also have with us Ms. Christina Cangroso, who is the owner of the Voice Forum LLC, which is like a modern day Bible for learning about voice and swallowing therapy. And I know many of us are her ardent followers.
Recording in progress.
Christina Kang and her colleagues have originally described muscle tension dysphagia, and we are so fortunate today to learn directly from her. Welcome. Finally, I would like to welcome my co-moderator of today's webinar, Mr. Mario Landera, who is the Chief of Speech Pathology and Associate Professor in the Division of Speech Pathology, Department of Otolaryngology at the University of Miami, Miller School of Medicine. After the three talks, we will have ample time for the question and answer session. So we request you to please type your queries into the Q&A box, not the chat box, the Q&A box, so that they may be addressed at the end. And thank you so much, Mario, for agreeing to moderate the questions at the end of all the talks. May I now request Dr. David Lott to start today's webinar with his talk on muscle tension dysphagia, a physician's perspective. Dr. Lott, over to you.
Thank you very much for the introduction, and thank you for having us to speak on this topic. This is something we're all very passionate about because we think this is, really something that can help a large group of people. So I'm going to speak today on the some of the background data that we found to support this concept, the theoretical framework as to why we think this is the case, and then just a real brief discussion on what we think the minimum evaluation or workup is for muscle tension dysphagia. So I'm going to share my screen. Hopefully you guys can see this when I share it. Are you able to see it now? I'm hoping that's a yes. I'll take that as a
we can.
Yes, we can see you. Thank you.
All right, thank you. Appreciate it. All right, good. So I want to start off by discussing kind of how this originated. We see a lot in our laryngology clinics. Patients that come to us with symptoms of dysphagia. There's something's off with their swallow. They necessarily can't quite put a finger on it. We get a modified barium swallow or video fluoroscopic swallow study. That's what the VFSS stands for. It just means a swallow study. And we see normal findings. We don't really see anything on their exam that would lead to why they may be having these dysphagia symptoms. And oftentimes we just say, well, there's no cancer, there's nothing we can find, come back and see if something gets worse. Over time, we started noticing that a lot of these patients also had other complaints, and so we would do a laryngoscopy exam to take a good look, and we noticed that they all had evidence of excessive laryngeal muscle tension. So a lot of squeezing, either during phonation and sometimes even during quiet breathing. You see a lot of squeezing in the larynx system. And then many of them also had other signs of what we call laryngeal hyperresponsiveness. That's what LHR stands for. Things like chronic cough or paradoxical vocal fold motion, globus sensation, or muscle tension dysphonia. So we started thinking, well, maybe these idiopathic functional dysphagia patients are really caused by excessive tension in what I like to call the laryngopharyngeal apparatus musculature. And I'll go into why I use that long, complex term, but I think it helps with this concept. So we set out to take a look and really understand, there may be some correlation between the two of those. So this paper was published back in 2016. And we looked at over 600 video fluoroscopic swallow studies and identified 67 patients that had a normal swallow study but had dysphagia complaints. 2/3 were women, and the age range was all over. And what we found was that get this here, about 97% of the patients that had dysphagia complaints in a normal swallow study, 97% of those patients also had increased laryngeal muscle tension on their laryngoscopy exam. Their complaints were things like food kind of sticking in the throat, or difficulty swallowing solids a little more than liquids, throat discomfort or pain when swallowing. Those tended to be the most common complaints that we saw. And about 2/3 of these patients also had some other type of hyperresponsive symptom, like again, globus sensation or throat pain or chronic cough or spasm. So something else that kind of led us to believe, gosh, maybe there's both a kind of a sensory and a functional component to what we're seeing here. 55, so more than half the patients had complaints of dysphonia also, so they also had voice complaints that went along with some of these other things. So we saw laryngeal hypertension, hyperfunction, laryngeal hyperresponsive type symptoms, and a high correlation with dysphonia. And so we saw this kind of 97% of patients that had this, that was coupled with dysphonia. We thought that maybe that these symptoms of dysphonia and dysphagia really weren't mutually exclusive, and that there may be some underlying hyperfunction that is really truly the underlying cause to both the dysphagia and the dysphonia, and perhaps even some of the hyperresponsive types of symptoms. We then took a look at how many of those patients went and saw Christina, who's going to talk a little bit later on, for therapy addressed at unloading laryngeal muscle tension. So a total of 13 patients completed voice therapy, and we found that all 13, so 100% of patients, reported symptom reduction or complete resolution in their dysphagia symptoms following the therapy that we'd normally give for muscle tension dysphonia. So to, again, unload muscle tension. So that led us to think, well, gosh, maybe there is a correlation here. Let's do a prospective study to really try to figure this out a little better and get a little better concept. So we took a look at, again, all adults that had a swallowing difficulty as their primary complaint, that had a normal video fluoroscopic swallow study. Some of the feedback that we got from our original study was, maybe these are really GI complaints, or they're having to do with reflux, because we didn't, in the first retrospective study, we really couldn't control for that. So we wanted to try to control for that a little bit better. So in order for them to be included in the study, they had to have undergone a trial of maximum dose PPI therapy for 3 months if they had already not completed an appropriate trial. And only patients that did not respond to proton pump inhibitor therapy were included in the study. All patients also were sent to gastroenterology for thorough esophageal workup and reflux workup. So they all had an EGD with biopsies looking for eosinophilic esophagitis. They all had high resolution esophageal manometry, and they all had a Bravo pH probe. And so we knew whether or not they had reflux or any sort of other esophageal problem. Excuse me. And then all patients again underwent therapy addressed at unloading laryngeal muscle tension. We took a look also from a laryngoscopy standpoint, and again, all these patients had, by definition, had to have laryngeal muscle tension on their exam. And 2/3 of patients either had some evidence of NLI, the terminology for that is non-specific laryngeal inflammation. So they had some sort of irritant that we could see that was either from reflux induced or some other issue. And 65% also had laryngeal hyperresponsive type of symptoms. The primary complaints were difficulty swallowing and pain with swallowing. And a decent proportion also had developed a fear of swallowing over time just because it was painful or difficult for them and they were afraid they were going to aspirate. The most common consistency that was difficult was, again, solids. So similar to what we found in the first study. Secondary symptoms, the most common ones were dysphonia and chronic cough. So again, 60%. The previous study was 55%. This one is 60%, so pretty similar. And then chronic cough, a symptom of hypersensitivity was there. And we found that most patients, or about half of patients, had more than one of these secondary symptoms, with the most common being dysphonia and chronic cough. Looking at improvement after therapy, so all patients described symptom improvement, and that symptom improvement ranged from 80% to 100% with a mean of about 91%. So that's a pretty significant improvement with, again, just therapy addressed at unloading laryngeal muscle tension. The vast majority of patients had that symptom improvement with 4 sessions or less. And people that tended to recover better fell in that group, which makes sense. If you recover, you're not gonna have more therapy sessions. This I find really interesting. So the patients that had reflux, diagnosed by gastroenterology and trialed on PPI therapy and did not have their dysphagia symptoms improve. Their mean dysphagia symptom improvement was actually even higher than the other group. So their main symptom improvement was 97%. And the reflux severity index decreased from 22, or it's almost 23, down to 22 to 12.7. So a significant drop in their symptoms of reflux. So again, not only did their dysphagia symptoms improve, but their symptoms of reflux improved, just with therapy at unloading muscle tension. And we take a look at that and say, well, is that really a significant effect for patients? And the effect size, anything greater than 1 is a significant effect, so it makes a difference in patients' lives. And this was also a significant effect for them. So a big benefit for these patients that had kind of these dysphagia symptoms. I'm not gonna go through these in detail, but everything highlighted in yellow was significantly improved, again, with the therapy. So the cough symptom index, the eating assessment tool, the laryngeal hypersensitivity questionnaire, the reflux symptom index, and the voice handicap index, all significantly improved in this patient population with essentially therapy alone. So what we concluded kind of from both these studies that, again, all these patients had laryngeal muscle tension on exam. There's a high association with dysphonia and other laryngeal hypersensitivity, hyperresponsive types of symptoms. All patients improved with therapy with a mean improvement of about 91% of their symptoms. And reflux does not appear to be the underlying factor. So even those patients that had persistent kind of GERD symptoms had significant improvement, again, with just the therapy. But those are the studies that we had done. There have been, since that time, other studies that have kind of helped support that. And so I'm gonna go through those quickly. Just so you can see what some of the other studies have found that helps us, again, to support this concept. This is a study that looked at the prevalence of dysphagia in patients with muscle tension dysphonia. So people coming in with a complaint of voice changes, how many of those also had dysphagia complaints? And so they looked at 44 people with dysphonia and 25 control subjects. And they found that in the people that have dysphonia, there was about a 41% incidence of also having dysphagia. And in control subjects that didn't have any dysphonia, there's only about an 8% incidence of dysphagia. So again, a significant difference, and shows you an association with dysphonia. This study looked at patients that underwent laryngeal manipulation. So again, kind of therapy for dysphagia when they had muscle tension dysphonia. And in this study, they found a mean subjective improvement of 77%. So again, with therapy alone, something treating dysphonia, they also had significant improvement in their dysphagia. This next study looked a little more in depth at this, and so they looked at comorbid dysphagia and dyspnea in patients that had dysphonia. So is there some sort of global laryngeal musculoskeletal problem? And so in patients that had dysphonia, they found an incidence of dysphagia at 44%. But when they looked at the E10 scores, that actually increased to 60.5%. So more than half of patients had clinically significant dysphagia in the patient population that had dysphonia. They also found that they had the patients that had dysphagia had worse voice impairment, and they also had worse problems with difficulty breathing. So something kind of tying in all the functions of the larynx that they found. And then when they looked at, again, therapy to address the dysphonia, they found that the dysphagia symptoms improved. About 96% of patients had either improvement or complete resolution of their symptoms. And if you notice that 71% of patients had complete resolution of their symptoms with therapy to address the muscle tension. So what we kind of get from this is there's that patient population that has dysphagia symptoms, a normal video fluoroscopic swallow study, laryngeal muscle tension, and a high correlation with other kind of hyperresponsive disorders, muscle tension dysphonia. It's not really just caused by reflux. And if you unload this laryngeal muscle tension, it improves the dysphagia symptoms in a vast majority of the patients. So why do we think this works? And this is, I'm just going to kind of go through this briefly on why there is this kind of global effect on the larynx. So if you think about the laryngeal priorities, what is the larynx really trying to do? So the main thing you do is it's designed to protect the airway. And then secondarily, also protect the airway, and third, protect the airway, right? So its main job is to make sure you don't get food or liquids down into your lungs. And then everything else comes secondary to that. And you've dealt with this in your own life. If you swallow something and it goes down the wrong tube, what happens is you start coughing right away, you can barely talk, you have a hard time breathing, and there's no way that you're going to be able to take another swallow until everything kind of settles down, because now you're hypersensitive. And so that's what the larynx does to protect the airway, is that you get increased muscle tension to help protect the glottis, the glottic valve, and you increase sensitivity to make sure that this doesn't happen again a second time. And so you can imagine a chronic irritant or even a severe irritant that had persistent problems afterwards. This is the picture you're going to have: increased muscle tension and increased sensitivity. And the problem is we tend to think of laryngeal functions as distinct. We kind of think of phonation and swallowing and breathing and sensation, but in reality, it's really a continuum, right? These are all the same muscles and nerves. They're just doing different tasks at different times. And an abnormality in one system will affect the other. If you have a change in the sensation, you're going to get a reflective change in the motor function. Same thing, if you have a problem in the motor side of things, then you're going to increase sensitivity to make sure that you compensate for that. Things that increase sensitivity, well, there can be a million things. So this is just a few of the most common types of things, but we know that things like anxiety and depression, or reflux, or postnasal drainage, viral issues, experimental exposures, central sensitization syndromes, those types of things can all increase sensitivity. And so it's really important to understand what are some of the irritants that may be perpetuating the sensitivity. How does the larynx respond when things are getting overly sensitive? So there's three ways. There's a hyperalgesia, which makes you just, again, more sensitive. Paresthesia, which is where you get abnormal sensations, so like a globus sensation in your throat. And allodynia, which is painful, right? So that's what we saw in a lot of our patients, is they had pain with swallowing. And so these are all signs that there's a hypersensitive process that's going on. And then again, knowing that sensory can cause motor changes, there's that interplay. We have to try to figure out how that interplay comes together. So hyperfunction can be either a primary muscle hyperfunction issue or as a response to hypersensitivity. So how does that manifest? If we have one of those many things that's causing some sort of laryngeal irritation, that gets either hypersensitivity or hyper-responsive muscle tension, and those two can interact with one another. And then the main things the larynx does, so sensation, it's manifested by things like globus, right? An abnormal sensation or a dysphagia or whatever it may be. Breathing is manifested by things like paradoxical vocal fold motion or chronic cough. Voice, muscle tension dysphonia. But when it came to swallow, we never really had anything. Well, I don't know why we kind of forget about swallow. It's a major function of the larynx. We really didn't have anything to describe what a hyperfunction would look like in the swallowing realm. And that's where we think that muscle tension dysphagia fits. Right? So muscle tension dysphagia is believed to be a disorder of hyperfunction. But remember, the larynx is not an isolated structure, right? It's a complex apparatus composed of multiple pulley systems guided by sensory input. Right? So there's the nerves and the muscles that are making the larynx move, and that's all guided by sensory input. So we all know about the intrinsic laryngeal muscles that open and close the vocal folds, and we use them so much for phonation. But we tend to forget that the extrinsic muscles also have a big play in all of those systems, right? We know that all these muscles and everything actually govern our pitch regulation, governs our ability to breathe and our ability to swallow. So the strap muscles, the constrictors, and cricopharyngeus are all activated in everything that the larynx does: voice, swallowing, and breathing. And that's been shown in the literature. I just don't have time to get into that. They all insert into the larynx. They all share redundant information, and they're all affected in abnormal kind of laryngeal tightness types of things like muscle tension dysphonia. Again, that's also found in the literature. So if muscle tension dysphagia is believed to be a disorder of hyperfunction, then you get tightness in this entire system, right? So you get invasive tongue tension, poor, slow, hyolaryngeal excursion, abnormal laryngeal positioning, decreased constrictor control, and incomplete CP relaxation. So what does that look like? So if you look at the kind of the cascade on how we swallow, if tongue retraction is off just a little bit, it means the hyoid elevation may be off a little bit, and the larynx and the thyroid and cricoid cartilages may not move quite well, which then means the pharyngoesophageal segment doesn't quite open up very well, and that segment then doesn't get pulled open very well. And it doesn't need to be significant, not to the point where we can actually see it on a swallow study, but because everything happens so quickly in the swallow, just a little bit of timing that's off where the segment doesn't open up very well can lead to symptoms of, gosh, solids or food is getting stuck. It hurts a little bit when I swallow, just because the timing is off just a bit from that. All right, so one last kind of slide, or a couple thoughts on just the proper evaluation of what we should be doing when these patients come to our clinic. One of the big concerns that we had received when we discussed muscle tension dysphagia is that people will just start diagnosing muscle tension dysphagia for everything. And no, it's obviously very important to still do a thorough, complete workup of muscle tension dysphagia. So we published this paper just last year, a few months ago, in the Academy Bulletin, so if you want to go see that. But essentially, it's talking about what is the minimum assessment we need to do for these types of dysphagia patients. And what we think is appropriate is a complete swallow evaluation, a radiofluoroscopic swallow study involving a thorough history and head and neck exam. So again, making sure there isn't a cancer or some other structural issue. Doing a laryngoscopic evaluation, again, to look at the laryngeal function and to rule out any anatomic defects. And then instrumental evaluations of oropharyngeal swallowing. So is this things like manometry or fees or those types of things to kind of get an idea of what's going on with the oropharynx. And then doing a true thorough esophageal evaluation, like maybe an esophagoscopy or a transnasal esophagoscopy, to look at the esophageal component and make sure there isn't a problem. So what we do in our clinical practice is all patients get a transnasal stroboscopy and videofluoroscopic swallow study. Some patients we consider a transnasal esophagoscopy. If there's no concerning clinical suspicion, we initiate therapy. Again, the mean duration of therapy is only about 4 weeks. So there's, if they don't respond like we think they should, there's only about a month delay for some of these further investigations, and it takes time. So you can plan on getting an esophagoscopy down the road, but you might as well start therapy up front and see if they respond. You have to have a low threshold for suspicion to make sure that something else isn't going on that can be causing dysphagia. And again, therapy can be started at the same time or wait for symptom resolution from other management. So in conclusion, muscle tension dysphagia, again, is believed to be a disorder of hyperfunction. Studies show tension throughout that entire laryngopharyngeal apparatus. There's a high association with other hypersensitivity and hyperresponsive disorders. It's a diagnosis of exclusion. Currently, we don't have anything to definitively say, hey, this is muscle tension dysphagia. And the evaluation depends on what the presentation is. Stroboscopic laryngoscopy, videofluoroscopic swallow study, TNE, have a low threshold for GI evaluation. And then to manage things, again, control those irritants, address the hypersensitivity, and then address the behavior modification that Christine is going to be talking about later on. So thank you all for your attention to this. I think we're going to answer questions at the very end, so happy to answer questions that you all may have. Thank you.
Thank you so much. That was incredibly lucid, Dr. Lott. I'm looking forward to, I think all of us are looking forward to the Q&A session in the end. May I now request Dr. Rosso to take his talk on identifying patients with muscle tension dysphagia. Dr. David Rosso.
Good morning, good afternoon, good evening to everybody. Is everyone able to see my screen now?
Yes.
Perfect. So thank you to Dr. Lott for that excellent presentation, going over all of the ways that muscle tension dysphagia was discovered and elucidated with a lot of really good data supporting this diagnosis. I'm going to talk a little bit more about the reality of how to determine which patients have this and where some of the ideal settings that were discussed at the end of the talk may collide with the reality of the real world. I have no financial disclosures. I do want to briefly say that the American Academy of Otolaryngology is having its annual meeting this year in Miami. It will be at the end of September and beginning of October. Please do try to make an effort to come. For those of you who are from India and the Philippines, Miami is the only part of the United States that has the same climate zone, so you should feel right at home. And it truly is a tropical paradise. So how do we triage patients that we suspect have muscle tension dysphagia? One of the things that spurred me to write this talk was the controversy regarding this. And it has not been completely universally accepted by all providers. In fact, one of the most prominent physicians, who I'm not going to say, has come out very strongly against the diagnosis of muscle tension dysphagia, saying that the phrase is dangerous, saying that the sensation of food getting stuck or problem swallowing liquids cannot be attributed to muscle tension in the throat or neck, and then goes on to list a number of potential diagnoses that can be missed, saying that widespread use of this term without a comprehensive swallowing workup from lips to stomach, a so-called exhaustive search, will lead to misdiagnoses and adverse outcomes, and that this is a catchy and convenient term. So this was back in 2019, 3 years after the original paper was published by Dr. Lott and by Christina. Now, the second factor that made me think about this talk was a paper that we wrote in ENT Audiology News in May and June of last year, reviewing muscle tension dysphagia. And again, you can see in the title of the paper, it says that this is clear that this is a diagnosis of exclusia, and it's important to rule out other causes of dysphagia. That's fine. I received a communication from a colleague in New Zealand who, thanked us for the paper and said, we're struggling to cope with the enormous number of referrals for what turns out to be globus. But our general practitioner colleagues are still describing these as dysphagia, and our gastroenterology colleagues have similar volumes. This physician is coming from a public health service that was just not able to handle the burden of patients who are coming in for clinical examination or even for radiography, meaning a video fluoroscopic swallow study. So that's what made me think some more about the fact that we've said that these patients who we diagnose with muscle tension dysphagia must have everything else ruled out, because that is an ideal directive for a world that has infinite resources. And unfortunately, this is a world with finite resources. Especially for public health systems, it's very difficult for them to provide a full workup for every patient with dysphagia. There's considerations not only of cost, but also geography. If patients live in rural areas that are several hours from a major medical center, it may be not feasible for them to come in to have esophageal manometry on a moment's notice. It's also a function of limited personnel. There just may not be enough practitioners in a given area to be able to establish this full workup for every patient that we suspect with muscle tension dysphagia. And it led me to question, are we really doing what's right for the patient in doing these exhaustive workups, or are we practicing defensive medicine? Now, without going into the actual details of cost, the main diagnostic tests that we use in the workup of a patient presenting with dysphagia, not only do some of them cost quite a bit of money, especially transoral esophagoscopy and manometry, but look at the number of personnel that they require, usually at least one physician, sometimes two, a speech pathologist, sometimes a nurse or a technician. And then there's very expensive equipment as well, not to mention the time that's used in that equipment or in that facility. Many health systems have a limited amount of space or time for patients to undergo radiology studies. And so flooding the system with more patients for a modified barium swallow or a VFSS on just the slightest hint of dysphagia may not be in the best interest of everybody. So I wanted to give you a couple of examples of patients. These patients were both seen this week in our clinic here in Miami, and just the contrast between them and how it sort of guides your decision making. So the first patient was a 24-year-old woman who presented with hoarseness, a sensation of food getting stuck, vocal strain, and excess burping. She did not have much of a medical history, but did have a history of anxiety. She was mostly a non-smoker, although she occasionally smokes hookah. She works as a waitress at a noisy restaurant, has previously been treated for reflux with omeprazole and famotidine. She does have some tenderness in the thyroid space. Her laryngoscopy, other than two very small bilateral vocal fold nodules, was otherwise unremarkable. So I question to you, and just as a thought exercise, do you think this patient needs a VFSS or other diagnostic testing? And would this patient be appropriate for a trial of therapy without further testing? So then the second patient I want to present is a 70-year-old woman who came with frequent choking episodes with solid foods and pills for several years that has been getting worse. She has a long-standing history of GERD, of gastroesophageal reflux disease, had a fundoplication surgery 15 years prior, but is still bothered by GERD symptoms. She's an active smoker. She has had unintentional weight loss over the last 5 years. Her physical exam is unremarkable, but her laryngoscopy was significant for posterior laryngeal edema. You can also see some pooling of secretions in the hypopharynx, as well as a significant bulging from the posterior pharyngeal wall. I'll pose to you the same questions. Does this patient need a VFSS or other diagnostic testing? Would this patient be appropriate for a trial of therapy without further testing? So these are obviously extremes, but I think that they do illustrate the point. When we decide whether or not to give somebody empiric treatment or to do further workup, we make decisions like these every day. These kinds of clinical decisions are very common for physicians and other practitioners. We give antibiotics for patients with acute sinusitis without necessarily doing further testing. We give proton pump inhibitors or other medications for gastroesophageal reflux disease. If we have an elderly patient who has bilateral sensorineural hearing loss, we give them hearing aids. In all of these cases, these symptoms could theoretically be caused by a tumor. And you could say that we should do an exhaustive workup to make sure that every one of those patients doesn't have a tumor. But again, the reality is that that would overwhelm the health system in terms of need for imaging, cost, and use of personnel's time. So bringing it into the laryngology and speech world, suppose that you saw a patient who had a weak, breathy voice for 6 months and didn't have any other symptoms. And on laryngoscopy, you found that this patient had a unilateral vocal fold paralysis. What kind of diagnostic workup will you do? Well, the standard of care is usually to do some kind of imaging to rule out a mass along the recurrent laryngeal nerve. Now, if you saw the same patient, but they had had these symptoms of breathy dysphonia and they were stable for 25 years, and you found on laryngoscopy unilateral vocal fold paralysis, you may not necessarily need to do the diagnostic workup because it's very likely this patient has had the paralysis for a long time, and the chances of them having a mass on the recurrent laryngeal nerve that hasn't manifested other ways is very low. And this leads into a discussion of what's known as Bayes' theorem and the concept of pretest probability. Bayes' theorem essentially says that it's a mathematical description of how the context is an important factor for how we make decisions. And I've adapted all of this from an excellent website called the nmt.com, which provides a lot of evidence-based medicine and statistical guidance. And according to Bayes' theorem, there is no perfect diagnostic test. And because we know that every test that we order will at some point be wrong, the likelihood that a test is right is going to depend on its context. And so when we're deciding whether or not to order a test, we estimate the probability that someone has a disease before we even order the test. And this is called the pre-test probability, the likelihood that a patient who presents with dysphagia has a more concerning pathology before we order the VFSS. So 3 unrelated clinical scenarios, but that I think illustrate this idea. Suppose you have a 35-year-old man who has a positive pregnancy test. This is clearly an incorrect result. And the result of it, the context of this test, the idea that a man has a 0 probability of being pregnant, is more helpful than the test itself. Sorry, I have laryngeal hyperresponsiveness. So, the fact that the patient had a pretest probability of 0 is critical for how we understand this result. Similarly, you could have a 19-year-old girl who has a positive cardiac stress test. Similarly, the chance of her having significant coronary artery disease is 0. On the other hand, a 65-year-old diabetic man who smokes, is having chest pain with exertion, a positive stress test is very likely to be correct. So for this patient, the pretest probability is much higher. So the test that we ordered is going to be more helpful. Now, applying this to the patients that I presented you before, the first patient, who is the young patient with vocal strain, globus, and anxiety, versus the second patient, who's older, has dysphagia, unintentional weight loss, and progressive worsening. So let's apply this considering which patient has muscle tension dysphagia. Well, the first patient is younger, has symptoms of vocal strain, has globus, anxiety, stress, has tenderness on physical exam, is a non-smoker, and has reassuring laryngoscopy. Versus the other patient who has more concerning symptoms, true dysphagia with choking, unintentional weight loss, progressively worsening. So in comparing these two patients, the first one is much more likely to be diagnosed with muscle tension dysphagia and to benefit from therapy. Whereas if we are concerned about a malignancy in the hypopharynx or the esophagus, the second patient has much more concerning symptoms and signs, whereas the first patient, with her very young age and non-smoking history, is much less likely to have a cancer and to need further workup. So for the first patient, it seems perfectly reasonable to start with empiric therapy aimed at decreasing laryngeal muscle tension. Whereas with the second patient, who has more concerning signs, we would initiate a diagnostic workup consisting of a VFSS, a CT scan, and potentially other workups. Is it dangerous for us to delay further diagnostic workup in these patients? Well, the trial of therapy typically is 4 sessions. You should usually have a better idea. I will defer to Christina on this concept, but typically patients will start to see some benefit by 4 sessions, which is about a month. And patients who do improve can continue their therapy and avoid costly and time-consuming tests. Whereas if they don't improve or they continue to have symptoms, we have to then send them for further workup. I don't believe that a 1-month delay would have a significant impact on any worrisome pathologies unless the patient has an extremely aggressive malignancy. And I would posit that a patient who has such an aggressive malignancy would probably have other signs that would increase the pretest probability that they have that malignancy and would make you think that you need to do further testing. So revisiting this original message regarding the controversy of muscle tension dysphagia, the idea that the term is dangerous, I don't think necessarily is true. Looking through the common diagnoses that were given, the things that could be missed if you diagnose someone with muscle tension dysphagia, all of the ones that are in green, I don't think are dangerous to miss. I think it's important to make sure that you go back and reassess if a patient truly does have an organic pathology, has a structural pathology, including acid reflux or Webb's or cricopharyngeus muscle dysfunction. But I would say that the idea that the patient is having adverse drug reaction causing dysphagia, and you wouldn't sort of know that from taking a history, seems unlikely to me. So I think the vast majority of these diagnoses are things that delaying by 1 month to provide care and treatment, I think in the balance, it is better to provide the care. So an exhaustive, comprehensive swallowing workup from lips to stomach, again, as I mentioned, I don't think it leads to misdiagnoses if you avoid that. And I think that it's important to balance the needs of your other patients and of the health system against practicing defensive medicine and ordering a test on every single patient. I also think that in not acknowledging or validating the concept of muscle tension dysphagia, we are not necessarily, we're not providing good patient care if we don't do this. The exhaustive workup can take months. And we know, based on the data that Dr. Lott just presented, many of these patients do get better with therapy. This is something that has really helped patients who previously did not have an answer and basically went through a diagnostic gauntlet only to be told, well, nothing's wrong and I'm sure it'll get better. I would ask you, what harm does it do to start treating these patients' symptoms, even if they're waiting for diagnostic tests? We do the same thing when we treat a patient with the paralyzed vocal fold while we're waiting on a CAT scan. We still will offer them treatment. I don't think it should be any different here. So the general guidelines, which again, Dr. Lott has really mentioned in detail, and both of the publications really solidify this. But younger patients who have a globus sensation rather than a true dysphagia, you don't necessarily diagnose this in patients who are choking, have aspiration signs. Patients who are anxious or have signs of laryngeal muscle tension are definitely people who are at risk for this, and this will increase the pretest probability of this diagnosis. Obviously, you don't want to see patients with neurological signs, people who have muscle weakness or maybe fasciculations or fibrillations. That's more worrisome for a neuromuscular disorder. You shouldn't see someone with weight loss, a negative laryngoscopy, and ideally someone who has a negative videofluoroscopic swallowing study. It's not always going to be the case, but more of these factors that we see that are positive, the higher the pretest probability of muscle tension dysphagia. So just to conclude, as a clinician, I believe it is up to you to use sound judgment to decide which diagnostic workup or treatment to pursue. Obviously, the official stance is that this is a diagnosis of exclusion, but again, I think that that is an ideal world that has infinite resources. And in the real world, I think that we should consider treating these patients who don't have concerning symptoms, assuming that they have muscle tension dysphagia, in some cases even without a VFSS. And I know I may be crucified for that, but I think that's the reality. I would say you should always have a low threshold for further testing in patients who don't improve with therapy, because I agree that we don't want to miss those concerning diagnoses. Thank you very much for your time.
Thank you, Dr. Russo, for sharing your wealth of knowledge with us. That was truly a very interesting talk. Now we have the final important talk on how to actually manage muscle tension dysphagia once it's diagnosed. And we have Ms. Christina Cangroso, who is going to talk on muscle tension dysphagia, what we know. Over to you, Christina.
Sorry. Okay. Can you see me?
We don't have your screen. We are seeing you right now.
Okay. I don't know what happened. It just went. Can you see me? Share screen. Can you see me now?
Yes, that's right. We have your PowerPoint, but not in the full screen mode. Yes, perfect. Thank you.
Okay, sorry, just had a little sweat. Good morning, everybody. So you can see me now. Okay. Hi, thank you for having me. That was really a fantastic introduction, first two talks. So the treatment, I mean, I got not a lot of time, and then people are already asking about like how to do certain maneuvers to massage the larynx and whatnot. And but this is, I like to talk about something more global to consider in helping these patients. Okay, so the first thing when you meet these patients or you're assessing them, of course you want a full case history. You don't want to just say when did this start, or just nonchalant things. You want like what happened around the time, their life situations, because towards the as you progress with this talk, you're going to understand whole global spectrum of what we're looking at. And of course, if you have voice measurement tools and whatnot, go ahead and take acoustic aero, dynamic measures, and of course, if you have indices like voice handicap and eating tool, go ahead and do them. But that's something I'm not going to talk about right now. So what I look at is what's causing the tension. Is it primary? Is it secondary? Primary meaning if there's no other problems like cough or globus, they only have the swallowing issue. Or secondary meaning like do they have other issues like cough, globus, voice problem. And then I want to look at where the most excessive tension is, how they're breathing. Is it voice related? Because, like Dr. Lat showed, there are a lot of researches out there with people with swallowing problems as well as voice problems. And where does psychology play here? And so I like us to consider what's at play here. Ultimately the larynx. Yes, breathing, swallowing, whatnot, but it's what we know, what we associate with phonatory subsystems, right? So you have to have respiration down in the lungs and chest, and then you have to have phonation, the mechanism here, and you have to have the resonance, the filter here, and out comes the voice. But this also dictates how we swallow. And because I'm using techniques from muscle tension dysphonia and targeting unloading of the larynx, I'm going to associate that into this muscle tension dysphagia, okay? Because that's the technique I use. I look at the patient and I look at the three subsystems, and I want to know where the fault is or where the inadequacy is, okay? In a perfect world, respiration, resonance, phonation, they all work in a balanced way, in a very harmonious way, so you have a very smooth flowing laryngeal mechanism and sensory system. So, but there could be an imbalance. These are a couple examples here. If somebody can have really reduced respiration, really reduced resonance, and they have to compensate with the really hardworking phonatory subsystems. This is where we see a lot with muscle tension dysphonia. Like imagine just holding your breath. Just hold your breath right now and count from 1 to 10. 1, 2, 3. Don't you feel the pressure here? And immediately it goes into the laryngeal tension in the back. And here's somebody who has to do a lot of respiratory effort because something's wrong with the resonance area, or like the phonatory area may be compromised where the vocal cords don't need, for example, paralysis of the vocal cords. Because you're losing a lot of air, the person's having to use more air to talk. So there's a lot of considerations here and possibilities of what can be off. Okay, I know people who are completely fine. Their lungs are fine, resonance system is fine, but then they end up with this press phonation because that's society. Look at like Kim Kardashian talking like this. Anyway, I'm nothing against her, but I'm just making fun of her. But sorry. Like we're used to people like talking like with press phonation, and husky voice is considered sexy, whatever. And so it could be just a habit. And when I'm assessing the muscle tension dysphagia, of course, when I'm meeting the patient for the first time, I do a trial massage. I kind of palpate everything and see what's stiff, and then kind of get a general sense of where they are. And you can also understand that the larynx, the hyoid bone, where it's hanging, the hyoid bone is like the only free floating bone in the entire body, not attached to any other bone. Look at how many muscles are, inserting in there. So if these muscles are tight, imagine the hyoid bone being really tight and your larynx hangs from it. You get the picture. And so I look at the person, is a person relaxed facial expression, just sitting there talking and breathing, and like, is there a difference between when they're just breathing versus when they're speaking? And then is their tongue like, do they like really not move their tongue when they're talking, kind of swallowing the word, and like, you could usually tell the tongue root tension, have them stick out their tongue, how extensive can they stick it out and move it around? And then the jaw tension, and then they sometimes like don't move their soft palate at all. A lot of times, I'm an opera singer by training, but a lot of opera singers come in talking like this, and like soft palate is really tight and elevated, and so that's a problem too. And then pharyngeal pillars, you can put a glove and then go in there and then massage the pillar. And a lot of times, patients will even cry because it's so tense, and then that'll open up a lot of tension, and then of course neck and shoulder tension. And breathing is huge. Like in the example I just showed you, you hold your breath and talk, and immediately goes into, laryngeal tension, right? And faulty breathing alone can lead to muscle tension dysphonia, just like I described here. And then look at how many people walk around holding their breath, right? And then most people, diaphragmatic breathing is, the diaphragm descending for inhalation and elevating for exhalation, and your rib cage is being nice and loose, versus people breathe with upper chest, first couple rib cages, and trying to raise their breath, and that's associated with anxiety a lot. And you want to have respiration that is coordinated with ease. Okay? And then a lot of times this faulty technique is even worsened by picture having a wrong anatomical knowledge of the function of the diaphragm. A lot of people say, sing from the diaphragm, speak from the diaphragm, and then they'll like do this. So just a good education alone can really help. And paralaryngeal palpation, like sternocleidomastoid, this muscle in I knew a chiropractor. He said, when he was taking the board exam, the trick question is, what is the SCM responsible for? And then it was for breathing. It's really prominent with clavicular breathers. And a lot of times with muscle tension dysphonia, you can see them like this pop with voicing. And of course, the scaly muscles, anterior, medial, lateral, and it reduces the neck range of motion. And you saw the picture of all the neck muscles intertwined, and you can't think of the neck is just an isolated thing. There's so many neighbors helping each other, just like an elephant's trunk has thousands of muscles doing one motion. I like to think about our body, our neck and like shoulders, they're all helping each other. And the larynx has to be really supple. It should be mobile, free flowing. If it cracks, that's crepitus, that's normal, but it should feel easy and not like fighting. Oops, sorry. And suprahyoid, above the hyoid, tongue base through here, it should be nice and loose, and it shouldn't. It should feel like marshmallow. Whether you're just breathing or you're talking, mine moves nice and loose. Parahyoid, it should be mobile, lateral, free range of motion. And the thyrohyoid membrane space between the hyoid and the cartilage, there's a membrane space. A lot of times it's hard to find if you have really compressed space here. This, you should feel like there's a little bit of divot right here, and you could, because it's a U shape, you can massage in and out. And when I assess patients and I start palpating there, a lot of people scream. They'll like start tearing, but then the pressure I put is literally just minimal. And I press their fingers. This is about the pressure I put on your throat right now. Is that how it feels? They're like, no, give me between 1 and 5, 5 being the greatest, and they'll say it's like 8. And so those are the things I try out during evaluation. And if they're amenable, I sit there and like massage in this thyrohyoid membrane space, nice and easy, really gentle, asking them to focus on diaphragmatic breathing, relaxed breathing, and then within 5 minutes, and they'll have a bigger space, and then they'll say, oh my gosh, I can swallow better. Because a lot of times with people with MTDG, of course they come in and say, I can't swallow solids, but most of the time they'll say, I have trouble swallowing my saliva as well. Okay? And of course, we live in the cell phone era where everybody's doing this. And when I ask my patient, where do you think your cervical spine is? And they'll usually say back of the neck here. They have no knowledge that it's right by the ear. And so they walk around doing this rather than finding the ear to shoulder balance, and so that you don't overwork the upper trapezius muscles and other scalene muscles and whatnot. And also, um, when posture is off, the center of the gravity shifted, so it like moves the head forward and everything gets thrown off, and then that bothers the hips, which ultimately ends up bothering the one, two, three, the cervical spine and the shoulder areas. Sometimes you can just ask them to put the shoulder back and immediately readjust everything all by itself. Of course, we all only think about up, but lateral is also important too. If you have a young person with a backpack doing, on one shoulder all the time, they're like asymmetrical. When I adjust them using Alexander technique and whatnot, their lateral ribcage mobility can increase even by 2 inches. That's huge for, ribcage movement and respiratory capacity increase. And so a lot of people with a swallowing issue with muscle tension have voicing pattern issues. And most of the time when I get inquiries online for needing help, I I agree to help them if I could hear that it's mostly muscle tension from voicing problem, because that I can do, I can help them online with. I can't reach across the screen and massage them, right? That's kind of scary. So I listen to how they start their voicing. Is it like breathy or is it like really hard? Like, if it's breathy, I immediately ask them to go get laryngoscopy. I don't want like them having a paralysis that we don't know about, or glottic gap of any kind of cause. It could even be like nodular, but breathy sometimes just makes me go, headlights in my brain. And then if they sometimes talk, when they talk immediately, larynx spikes up, you know, and that's called high carriage. And they throat clear like every time they try to talk, like, and then start to talk and offset to talk. And then they complain of mucus every time they talk. That's why like they have to throat clear. But I tell them when when we do laryngoscopy, there's no mucus in the throat, like not any globs or anything, but the sensation of muscle tension feels like mucus. Mind blown, right? Okay, and then voice has to be balanced in vibration. Are they talking in vocal fry all the time, like stuck in their gutter, or um, any other issues like that, hypernasal, um, like do they like talk too loud, too soft, a lot I'm looking at here. So, and then I have to think about other concomitant disorders like laryngeal hyperresponsiveness, chronic cough, globus, vocal fold, paradoxical vocal fold movement when the vocal folds close rather than stay open when they breathe. That's due to sensitivity because it thinks it's being attacked. Um, and then also I have had people who go get traditional swallow exercises, and then it made everything worse because they're already tense, but strengthening exercises make it even more tense. So there are times when I help people reduce the laryngeal tension and then prescribe the strengthening exercises, because then we're doing it on relaxation. Um, Also, phagophobia, they develop fear of swallowing, and then that is something I had to have. Okay, so there is something called McNeil dysphagia therapy program, is where they you just have them swallow, 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 swallow. Don't think, just swallow, 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 and then they have to swallow consecutively 4 times. I think it's 4 times. Sorry if I'm wrong, with no coughing or aspirating signs to be able to move to the next consistency. So I actually took that therapy program, but before that, I actually had people just swallow, swallow, swallow without thinking, because phagophobia comes in because fear of swallowing. Who is in fear? The brain, right? And so that kind of retraining for fear of swallowing is maybe necessary. And central sensitization is also called chronic pain syndrome. It's where brain learns pain. And there's stress can affect people in many ways. There's physical, emotional, mental, but I didn't include that here. I only included the physical manifestation for Mayo Clinic. But look at the red ones: dry mouth, tight throat, breathing problem, indigestion, heart itchy, all these things that you hear from your clients all the time. So you have to start thinking about, are they manifesting chronic pain? I asked them if they have other other issues in their body. A lot of times they could have autoimmune diseases, or they have diabetes, in other tingling sensations in the body. And I just kind of want to look at paresthesia, the neuropathic uh, symptoms that I have to kind of consider, which makes them more susceptible for chronic pain. Because the brain learns pain, people who have learned to have sensitive throat will have sensitivity even faster than other people who don't have that. And when people have chronic pain and they have this sensitization problem, they start catastrophizing. Catastrophizing is like a destructive negative thought that makes small thing even worse. So that they constantly focus on the fact that they have trouble swallowing, and this also leads to that fear of children. And it's learned, it's a personality, people who have like very anxious traits and negative emotions or mental health struggles to do. It's coping mechanism, it's supposed to help you, but sometimes brain helps you too much. And then the people start to just feel worn down, and they start to avoiding social situations, they don't want to meet with people, and then they just start to overthink about it. And it's catastrophizing, if you see a lot, and there is an index to that in the research as well. And so what to do during catastrophizing, of course, this is where mindfulness comes in. You have to retrain the brain. Whenever you start to ruminate about the experiences that you have to switch it with actual realistic things. Like, for example, I tell people, there was someone who wanted to have food every time they had a meal. Like, they come in and I want to food, I want to make sure they're in fall and good. And after a while, I said, we have the evidence that you can't find. You have to tell the brain not to be scared and, teach your brain constantly, like a mantra, tell your brain that you can find. And then you have to avoid questions that remind you of the pain. I don't tell my house patients, oh, it's hard. I don't do that. I say, how have you started to be consistent? I have to focus on action, not feeling. So same thing with the symptom. You can't deal with the feeling, but the feeling is always the person that you can follow. But the fact that they can feel. So I have to focus on the actual behavior. So I do a whole other talk on chronic pain, which is an hour and a half long thing that I do frequently that's related to the language sensitivity, because it's just tiny fraction of snippets in that. Just remember that when you remind the brain of the pain and the problem, the more it will think about it. Okay, so other interventions to consider is, of course, we talked about unloading the muscle tension. Now yourself, you had a lovely lady from Germany who did 4 sessions, 4 weeks, but twice weekly, more fasterly. So 3 weeks of muscle tension dysphagia sessions, and then it's totally recovered. Hallelujah, wonderful, right? And then other people who have used resonant wave therapy, semi-occluded focus strap, your stress image, and things to promote breathing better, just anything that can balance the 3 circles, respiration, resonance, and information. Anything that can balance them is the name of the game here. So yes, sometimes you can go and like massage the person and then all right, it does hurt, right? But that is actually the much rare case. They may feel better in that moment, but they just and they get worse again and they come back, and then they end up giving this dependence on the clinician. This is why I always say, try to figure out where the tension is coming from. Is it physical? Like, so where can you focus on? If you think it's just the respiration, it's very just the respiration, because you have to tie the respiration to phonation. So phonal respiratory coordination is what I tend to focus a lot on, facial and how it can go through history and dealing with the children. And then diaphragmatic breathing, a lot of times, just cutting down to the exercises without focusing on that relaxation aspect is sort of like a wasting both my time and their time, because they're doing this all in intention. And just break everything down. I tell them, we're building a house here. Let's start with the foundation and then start putting the brick mortars and whatnot. But the foundation is going to be relaxing your brain, and that is through breathing. Research shows us that the diaphragmatic deep relaxation breathing works far better than any medication. So training so that they can have this low abdominal breathing, which should be 24/7, because that's already how they breathe when they sleep. And to be able to do that when they're awake and aware consciously with mindfulness, so that they can body scan themselves throughout the day, that they're not holding their breath, which would exacerbate any kind of tension. And if they're breathing better, they're checking in their anxiety. It just helps the person in general. So that's what I tend to focus on the most when I first start my first session. And then a postural alignment, you can, Alexander technique is what I use because that's my, that's my opera training background. But nowadays, mindfulness training is huge with posture too. So that's something I'm really glad to see happening out there. Progressive relaxation, even meditation, yoga is wonderful, but I do not condone yoga like workout. I'm talking relaxation hatha yoga. People who go to yoga and then like doing power yogas, lifting weights and like really pushing their body, that's not for this. Okay? And most often than not, I have to refer the patient to psychotherapy because I'm not a psychotherapist. There's other issues that are making the patients stay anxious, and that is not my scope of practice. And use technology. Curable, this app here is like chronic pain therapy on the phone. Of course, you have to pay for it, but it's not a lot. And then it teaches you a lot of strategies to retrain the brain, to step away from the fear and then the pain matrix cycle, and then a lot of breathing apps. I cannot promote enough about balanced breathing. It just, sometimes I just do 10 minutes of breathing and then the patient feels better already, and then they realize, oh, I'm much more relaxed, and this is across the screen. So that's the gist of introduction of what I look at in a theoretical framework when I work with clients. Now, if you want like actual manual therapy instructions and whatnot, that's a whole nother webinar. And I'm not sure if I can do that like as well across the screen. But if you have any questions, you can always email me at my website. Thank you.
Thank you so much, Ms. Christina Cangroso. That was an incredibly useful and enlightening talk. May I request Mario Landera to please moderate the Q&A session?
Yeah, fantastic, everyone. Great presentation. There's a lot of interest in some of the questions that have been coming up. So one of the first questions, or several questions I've been asking, if slides or recording of the presentation will be available.
There should be a cloud-based recording of this, and what we can do is probably post a link to the recording in the chat at some point if I can find it.
Perfect, thank you. One of the questions was asking about a difference between globus pharyngeus and muscle tension dysphagia.
Okay, so globus pharyngeus is like sensation of a lump in the throat. I've had this from severe reflux. That's how I got into this whole thing 15 years ago. And it feels like a ball in there. And I even used to put my finger in there to try to fish it out. That's how dumb it was before I did all this. So that resolved, the globus resolved for me with PPI, proton pump inhibitor. But it also led to muscle tension dysphonia because I was so tense. And so that resolved with therapy. So does that make sense?
Yeah, very good, thank you. Another question, and maybe this one I'll answer. I'll ask two questions in one because they're kind of related. There's questions about muscle tension dysphagia and functional or psychogenic dysphasias, and if there's any role of anti-anxiety meds.
I can add some of, maybe answer some of that. So again, I think, if you, from that slide at the very end of my portion of the talk where we talked about the irritants, then there's the actual physical hypersensitivity component, then there's the actual motor changes to it. The psychogenic part of it, remember, that was one of those irritants for the larynx. So the anxiety, environmental exposures, all of those types of things. So yes, absolutely. We have to look at all of the things that can irritate the larynx and treat those. But sometimes the hyperfunction takes on a life of its own. So you may treat the reflux, you may treat the anxiety, you may treat whatever it is, but the muscle tension persists. So similar to what Christina was talking about in her case, where she treated the reflux, the globus went away, but the muscle tension persisted. Same thing can happen from a dysphagia standpoint. You can treat the anxiety or whatever it may be, but now the laryngeal hyperfunction or the muscle tension has persisted, and you need to treat that in addition.
Yeah, perfect. Anyone else want to add? Yeah, perfect. Someone asked about a relationship between eosinophilic esophagitis and muscle tension dysphagia.
I think that in that case, eosinophilic esophagitis is the diagnosis. And I think that, again, that's where you have to be careful that muscle tension dysphagia is really more of a functional diagnosis. Somebody who has eosinophilic esophagitis needs to be treated for that appropriately, and not fall in under the functional diagnosis. For all those who are interested, by the way, I've just posted the link for the recording into the chat. The recording won't be available until a little bit after the webinar is done, but if you're interested, that will also be sent out to registered parties as well.
Next question, I'm going to go into more of the voice therapy or therapy aspect. So Christina, I'll ask you two questions. Someone asked, are you billing for voice or dysphagia therapy for muscle tension dysphagia, and any recommendations for courses for speech language pathologists or therapists to become certified for manual therapy?
Okay, so when I did the therapy in clinic, there is dysphagia NOS. I think ICD code for in United States, and if they have concomitant this MTD diagnosis, of course I will use that. And then for manual therapy, I highly recommend Walt Fritz, Fritz. He's a PT who does swallowing manual therapy courses. He has them on ASHA. Actually, if you go to my handle on Instagram, I think Walt gives a discount to the people who like follow me or whatever. I can put it on my Instagram handle as well. I like his approach. By the way, I make no money from him. I like his approach because he looks at the person holistically, and it's a very extensive course. It's not just 1 or 2 hours. His online course is like over 10 hours. So I highly recommend that.
Great, thank you. I'm seeing we're getting a lot more questions as we continue, so I'm going to quickly scan through some of these. Any role of electrical stimulation to help with muscle tension dysphagia?
No. There's no research evidence to support that. I mean, there's a lot of, Mario, you can tell us about the electrical stimulation in just any dysphagia.
Right, yeah, I think that it would make them more anxious. So I can see it being counterintuitive. And like you said, there's no research on it.
Well, I think the important thing is there is research on electrical stimulation, but it's confounded by the fact that those patients are also receiving therapy. Usually it's for boys, not for swallowing.
Right.
But I think in this case, I think the point is correct that the electrical stimulation is probably going to only exacerbate the muscle tension rather than, help relax it.
Right, because are we using the electrical stimulation to help brain relax? No.
I think this question was in the presentations answered this, but since there's several people asking it, how can we diagnose muscle tension dysphagia without a video fluoro or without any instrumental examination?
I say you can't. Muscle tension dysphagia is not a diagnosis; it's a consideration, in my opinion.
Right. And I'm the one who put out the controversial idea that you can, but you know, and again, I'm simply trying to be realistic about the approach to these patients in a world that doesn't have infinite ability to get a VFSS for every single patient. And yes, the by the rule book, these patients can't be diagnosed with it without having that study. However, again, I think that, you know, there are some patients where you will have that as a consideration more strongly than others. And I leave it, you know, to your sound clinical judgment, whether or not, you know, you could give these patients a trial of therapy, but maintaining in the back of your mind the idea that, like, you haven't officially ruled out other diagnoses yet.
I mean, I think that if you try few session of therapy, thinking about the whole person, like the respiration, phonation, just like the whole picture, and you really looked at the person, and then they haven't even made an inch on their progress. I think you can use that as a evidence to say, hey, how about we try to rule out other things? We recommend it. You know, we try therapy. Can we look at these things?
Yeah, and I would agree, just to put my 2 cents in there. Yeah, I think when you see these patients, there are people who clearly should really work up, and some people like Dr. Russo showed before, where, gosh, they probably don't have any significant anatomical disease, so you initiate therapy, and then if they don't respond, you can kind of get the swallow, you can get some other things too. You just always have to have a very low suspicion and concern. So if they're not improving, then you need to continue with the follow-up exam.
I have had a patient who did a month of therapy, did not improve. I encouraged him to go get his esophagus checked out. He had stage 3 esophageal cancer. So SLP can play an integral role in helping patients get a better diagnosis.
Yeah, great, thank you. And next one will be another combo question for patients that come in. What is the initial complaint? Is it going to be dysphonia or dysphagia? And what specific findings do you observe in a FEES for muscle tension dysphagia?
I don't like FEES for muscle tension dysphagia because I can't see what the oropharynx is doing. I only see aspiration and penetration evidence. So, but you know, with FEES, if I see residue and whatnot, of course I will be able to see glottic I'll be able to see, like, you know, the vocal fold, laryngeal motion and whatnot, but you can't judge glottic closure. There's so much missing with FEES. The complaint would be like, I feel like I can't swallow. And many other times these people with dysphagia sounds hoarse to me, but they don't complain about their voice because the voice is not important to them or not concerning to them. So many people are used to sounding hoarse. And they think that's just, you know, husky sexy. So they don't care about that. So if I find that they have dysphonia, a lot of times I have to have their buy-in for the therapy because I'm using voice therapy techniques, and they're like, well, I don't have a voice problem, but well, you say I have to do it to make my swallowing better. Okay, sure. So to get their buy-in, you know, it could make the intervention easy, or it can make it like really flimsy. Like they may not show up, and so many factors in there. Yeah.
We have a nice question from Ella asking for Christina. When and how do you typically encourage patients to seek psychological support in tandem with voice therapy? I'm thinking of patients who do not seem open to considering or denying a psychological component when they initially present to speech-language pathology.
Oh boy. Well, this is where I train them in the breathing, and I have them become more mindful about like what that does for them. If they do say, oh gosh, I feel much more relaxed, then I little by little introduce them to the relationship between what I'm doing and what I'm observing. And so you can't just tell them, oh, you need therapy, you need psychotherapy, because that will just blow people away and then they won't do anything. That's not what you want. So I use my the a cognitive behavioral therapy technique. I teach them like strategies I think they can benefit from. So as a clinician, if I'm aware of basic cognitive behavioral therapy, it can be very beneficial in helping them become more enlightened. But once again, breathing is huge, and a lot of these people come in very overwhelmed. And so this is another thing I do on my chronic pain talk, and I teach them basic strategies like what's important, what's not important, how to focus their energy, mental energy, so they don't start like ruminating or catastrophizing. And yeah, there's so much. Voice therapy is interesting, and it could be hard and very daunting for these factors.
Someone asked, do you have to be concerned for billing when using mindfulness techniques, or is it considered a modality of your therapy program?
It's my tool. I don't bill for it. It's just something it's eclectic, right? In voice therapy, you have psychogenic, symptomatic, hygienic, and physiologic, and you is combination of any of those that can help that person individually. So mindfulness technique is something I tend to use a lot to help patients become focused and be a better learner of what we're trying to do. And it's good for the clinician as well.
Great. Someone asked about explaining more on the oral trials that you do as part of the therapy techniques for patients who have muscle tension dysphagia.
Oral trials. I mean, once I help them unload the larynx, of course, I do some trial feedings. And then if I see them ruminating or like having fear, this is when I go, nope, swallow, 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 and then, get their mind off. When they start thinking about it, they shouldn't have to think to swallow, right? So get their brain to redirect and what is natural. And that's what I try the oral trials for. Or I have them bring food items that they're scared of. But I've had people who are clearly far gone where I couldn't help them because they were losing weight and they needed like anxiety medication and counseling in other ways. And those people, yes, I immediately refer out if I can't help them.
And along the lines, this question was just asked, do you ever have to recommend a diet modification if someone is struggling to manage certain foods, such as tough or chewy foods like breads and meats due to muscle tension dysphagia?
I have not had to do that. And I think that's like I said, you shouldn't have to think about swallowing because all the structures and everything are normal. They're just sitting there thinking they can't swallow, but after you do all the unloading and help, if their voice is balanced and everything, should they really have to think about swallowing? No, because structurally they're okay to swallow.
Perfect. Another question, can transcutaneous vagus nerve therapy help?
Doctors?
Yeah, punt it back to the doctors.
Yeah, so again, to me, that's one of those tools that I use for that middle box, which is the hypersensitivity component. I think that the superior laryngeal nerve blocks and those types of things really do make a big difference in helping to decrease that hypersensitivity, hyperalgesia component that we see.
Great. Back to the fees exams that are done with or without stroboscopy. Any hallmark features that differentiate muscle tension dysphagia from muscle tension dysphonia, or are they going to be similar?
Supraglottic compression. And of course, do the larynx, the glottic, does it open, close? Are they like really sensitive? Sometimes people with sensitivity, when they breathe, like larynx is like quivering more than like 20%. And all hypersensitivity signs and whatnot. I see somebody asking about cricopharyngeal web. That is, I don't doctors, can you see that from like, we can't see that on video?
Not an endoscopy, you shouldn't, unless you're doing a, esophagoscopy. You wouldn't see that on a fees or on a laryngoscopy.
Right, but even when they do EGD, not all the GIs rule that out, right?
An esophageal web generally should be seen on an upper endoscopy.
Okay. And TNE as well?
Same thing. Yeah.
Okay.
This question is coming up again, talking about treatment on hypersensitivity and hyperfunction of the laryngeal muscle.
Dr. Lott?
Yeah, so, that goes back to that whole series of disorders that fall under that umbrella. So again, my default is I go back to reducing the irritants or addressing whatever those irritants may be, and that's where that thorough history comes in, is to figure out, hey, is there anxiety, is there reflux, is there closing the drainage, whatever is going on. And then looking at that other component, which is the actual hypersensitivity itself, which is to either medications, things like neuromodulators or like the nerve blocks we talked about earlier. And then the last part of that is the behavior modification. That's kind of my general approach to this whole umbrella of disorders that fall under that hypersensitivity, hyper-responsiveness.
Great, I think we have time for just maybe a couple more questions. One is, what is the probability of muscle tension dysphagia in decannulated or tracheotomized patients?
Oh, Lord. I don't consider,
I'm not sure that would qualify as muscle tension dysphagia again, because there's already been an anatomic insult to the, if not to the larynx itself, to very near to it. And so I might define, if somebody's having dysphagia related to that, I think it might just be a function of the fact that they've had a tracheostomy, that they've had surgery in the neck. And I think I would sort of direct, treatment that way.
And in addition, I might add that, yes, obviously you have to kind of go down that road and treating those types of disorders, but like you see with muscle tension dysphonia, there may be a muscle tension component in addition to, so you may get at least partial resolution if you think there is a muscle tension component. Again, a lot of this therapy is going to be towards unloading that tension anyway, so I don't think it would hurt to send those patients. I just wouldn't expect that to be the entire reason why they have dysphagia.
All right, and I think I'm going to save a really good question. I think this would be great to wrap up this wonderful presentation. What other research is needed for muscle tension dysphagia?
So many people are already doing excellent research. They're trying to measure the actual tension, like by looking at differences in laryngeal elevation when they swallow, norm versus people with these problems, and voice research related to this, pharyngeal manometry. I know some people are actually using that to help people with this problem, but they're not publishing it yet. And I think more cohorts, more bigger population study would be helpful. But then, like when we did the efficacy study, we had like 80 people sign up and only ended up with 20, because as soon as the GI told them, "Oh, nothing's wrong with you," they all dropped out. So, hey, you get what you get. And
I would also say,
yeah.
oh, I'm sorry.
Go ahead. No, go ahead, doctor.
I would say also that, what we need is more studies looking at, are there questionnaires or are there other factors that allow us to diagnose these patients without the need for, instrumental swallowing? Because I think that's where the really helpful research would be, if you can identify factors that really positively correlate with ruling out other disorders and ruling in for this. I think that would help with the, what we discussed earlier about resource allocation.
Right. I see a lot of excellent questions on the Q&A that we won't be able to answer. Is there any way they could be forwarded and I can type an answer like to the people, or you can email me? Okay.
Since you've given your email, maybe we can encourage people to email you And maybe
Sure, I'll be really, really busy, but okay, sure. Okay. But it has to be, if I can't answer it, I will tell you, I don't know. Okay?
All right, well, thank you everyone for attending in this wonderful session. Those that are here, there is the link that Dr. Rossau put in the chat box, so make sure you download that. Any last words, Dr. Nupur?
just want to thank you so very much, all of you all. It's been an amazing experience hearing all of you all. And I think this is a topic which is quite new to us in India. So I think it's very useful. So I have to thank you, David and Christina, for really thinking about this. And I think it's going to help our population in India. And I'm sure there are people from all over the world hearing, but I do think in India this is going to be very helpful. And we will probably bother you with some email questions at some stage as we start treating these patients. So a very big thank you and shout out to all of you guys. Thank you so much.
At one point, if you want any kind of like actual treatment focused webinar, I'll be happy to do it.
Fantastic.
It will be long, but
We're
it'll
going to
be.
be very happy about that. So thank you. We will reach out to you for that.
Sure, thank you.
Thank you all.
Thank you, everybody.